Good morning, everybody. Thank you for coming to Primary Children's Pediatric Grand Rounds. I'm Miguel Canacal. I'm the one of the pediatric hospitalists and your course director. And today is Endocrine Day, y'all. It's a Rallison-Foster Memorial Lecture, so we're real happy about that. Today's Cloud CME claim credit code is 52525. 52525 for everybody to claim. So if you're online, the questions just go in the live chat, and if you're in the audience, if there's question time, you can just raise your hand, and the speaker can just kind of call on you, and the overhead microphones will pick it up, and you don't have to repeat the questions. Okay, and will you please nominate a safety hero when you see an event where somebody used one of our always safe zero harm techniques to prevent errors? This nomination that I'm telling you about is from our oncology unit, a nurse and pharmacist. They use the technique stop and resolve and also repeat back. So one of the oncology patients with a new diagnosis of medication-induced hyperglycemia just before discharge, kind of diagnosed on the last day they were there, now needed education on the insulin, long-acting and short-acting in Spanish. And another patient was waiting to get admitted. So, you know, the situation where there's time pressure or perceived time pressure to have another patient with cancer get admitted to the hospital. However, this nurse and pharmacist made sure to use the interpretation properly and prioritize the thorough education. It took till 7 p.m. before the nurse could declare the education complete. You know, she waited till the family could repeat back and demonstrate everything with the short and long-acting insulin, which numbers to call if there's a problem and everything else like that, so we're not rushing someone out the door. So when these things happen, when you can notice a situation that is ripe for error, time pressure, busy, Spanish speaking, or interpreter use, and the oncology nurse just noticed that, overcame it all with stop and resolve and repeat back techniques. Okay, I'm going to switch this. Yeah. Move this down. Now, Dr. Vana Raman, the Chief of Pediatric Endocrinology, will introduce the lectureship and also our speaker.
Good morning, everyone. Thank you, Miguel. Welcome to the Rallison-Foster Pediatric Grand Rounds. It's very nice to see Dr. Foster here with us this morning. It is my pleasure to introduce Dr. Adda Grimberg. Dr. Grimberg is a professor of pediatrics at the Perelman School of Medicine and a senior fellow at Leonard Davis Institute of Health Economics at University of Pennsylvania. And she's also the scientific director of Diagnostic and Research Growth Center at the Children's Hospital of Philadelphia. She received her undergraduate and medical education at Cornell University and completed her training in residency in pediatrics and fellowship at CHOP. She trained as a translational physician scientist. And Dr. Grimberg's research focuses on growth hormone and insulin-like growth factor axis and clinical issues related to children's growth. She has published over 150 scientific articles, reviews, and textbook chapters. Her research has been recognized with numerous awards, including the Pediatric Endocrine Society Genentech Clinical Scholar Award, the Robert Blizzard Lectureship, and coverage with multiple media venues, including the New York Times. Dr. Grimberg has chaired the task force that drafted the guidelines for pediatric growth hormone and IGF-1 treatment for Pediatric Endocrine Society and has served on various task forces for international societies related to growth hormone use. She was elected to the Council of Growth Hormone Research Society and has served on editorial board of Endocrinology Reviews and associate editor of the new edition of the Sperling Pediatric Endocrinology textbook. Thank you for joining us this morning, Dr. Grimberg. We look forward to hearing from you.
Good morning, everyone, and welcome. First and foremost, I want to thank Vana and Miguel for the very warm welcome and invitation to be here with you all today. So here are my disclosures, all related to invited lectures. But I also have another disclosure in that I have a relationship with Intermountain Healthcare that dates back to my fourth year of medical school when I did a 1 month rotation here with Dr. Frank Yanowitz in preventive cardiology. And Dr. Yanowitz and the entire staff were so lovely and so friendly and so welcoming and taught me so much that this really stayed such a pearl in my memory. And I must confess, this is also where this East Coast girl learned about real snow. So when I got the invitation to come back here and speak with you all, it really, really touched my heart. And I am particularly honored to give a named lectureship in honor of a cherished member of your endocrine division. So thank you, thank you. All right, so here are my objectives. That at the conclusion, you will be able to describe the normal growth patterns of puberty, discuss the role of gender in the medical management of short stature, and list the therapeutic options for delayed growth in puberty. And I must confess, in honor of Dr. Foster, I did pull in more puberty than the traditional straightforward growth talks that I usually give. So you'll get growth and puberty here. All right. So to start off with, you got to know normal variation. And as you all know, child growth proceeds in certain patterns. The most rapid growth actually occurs in utero. Afterwards, the most rapid growth postnatally is in the first year of life, a little bit slower in the second year of life. Then you have that nice steady childhood growth rate before you hit puberty. When the growth rate increases, that's your growth spurt, and then growth is done and you're an adult. And it's because of this reproducible pattern that we've been able to create growth charts. So of my entire talk, this is probably the single most important slide. If you remember nothing else from today, please remember this slide. Ironically, this is something that James Tanner published in 1962, and it still holds and is tremendous. And what he did was really study growth and puberty, described the Tanner stages. And as you see there, the pattern is in the sequence. In the left panel is for boys, and as you see, the x-axis is age, and then the different events are vertical. So the first event of puberty in boys is testicular enlargement. And what I want to call to your attention is that the growth spurt, the peak height velocity, is here towards the end of puberty in boys. Contrast that to girls in the right panel. The first event is breast development, telarchy. But if you see here, the peak height velocity of girls is actually earlier, stage 3 to 4, before they get menarche. So not only do boys on average start puberty later than girls, they actually get their peak growth spurt later in the sequence. This is another way to show the same data. And as you see there, the velocity on the y-axis, the age on the x-axis. So boys get their growth spurt later than girls, and their peak height velocity is a little bit faster than girls. And it's a combination of those two factors that leads to the average 5 inches that the height of the average height of men in the United States is 5 inches taller than the average height of women. And the way that we evaluate the rate of development or where a child is in development is, of course, by a bone age x-ray. So you take an x-ray of the left hand and wrist, and we're looking at the shape of the growth plates. So here is that of an 8-year-old male, and here is that of a 14-year-old male. And part of the reason that short stature and delayed puberty are distressing to kids and to families is this phenomenon of juvenilization. And what that means is that human beings are pretty much pre-wired to assess a child's age by their size. So looking at this photograph, even though we cannot see the faces of any of these 3 boys, we automatically assume that the bigger child in the middle is older than the other 2. And so what happens is kids who have delayed growth in puberty often are juvenilized. People say, oh, you're really in this grade? You're really that old? Do you belong here? They baby them. And that often causes distress and concerns about their social development. Okay, so what makes worrisome growth and puberty? Well, the processes that affect growth are as broad as the differential of general pediatrics. To start off with, in the middle, there's normal growth variation. We know that human beings come in all different shapes and sizes. So we have what we traditionally refer to as familial short stature, right? Tall people tend to have taller kids, shorter people tend to have shorter kids. In today's day and age, we now call that polygenic short stature because we understand that you can have monogenic or oligogenic short stature where you have one gene or a few genes that have a major impact on your height, and those can transmit in the family. And just because the parents haven't been diagnosed yet doesn't mean there isn't something going on. But healthy variation, short stature, polygenic short stature, through GWAS studies, they've been identified about 1,000 genes that each contribute like 1 millimeter to your height. So you put them all together, mix them all up, throw them, and that's how you get the breadth of human healthy variation. Also, normal growth pattern is constitutional delay of growth in puberty. So if you're a late bloomer, and if you have a background of familial short stature and you're a late bloomer on top of that, you can have pretty profound growth failure, or short stature, I should say. And it's not growth failure because you're perfectly healthy and perfectly fine. The next category I want to bring your attention to is the one on the right, GI diseases and nutrition. That is the biggest category worldwide. GI diseases and nutrition occur across the spectrum. So we tend to think of malnutrition, of course, related to food insecurity, but I have clinics in upper middle class and higher socioeconomic status, and I see nutritional stunting very, very commonly in my clinic. And that's because kids are busy. They're doing sports, they're burning up calories, they're running around, and either meals aren't structured, mom's not a good cook, mom doesn't like to cook, the kid doesn't like the food, the kid's a picky eater, they're on ADD meds, whatever the combination, calories in don't equal the calories out, could be subtle, but it's enough to hold back your growth. In terms of GI diseases, things like celiac disease, Crohn's disease. So about 2/3 of children with Crohn's disease have growth failure at the time of diagnosis. And many times the growth failure even predates their GI symptoms. So that is a very big category. Then moving around the circle, SGA and IUGR, about 85% of children who are born small for gestational age are small because of pregnancy issues, placental issues, maternal issues that become, history. And once they're postnatal, their intrinsic factors take over and they have catch-up growth. But about 15% of children who are born small for gestational age remain small, and that has become an FDA-approved indication for growth hormone treatment. Next, systemic disorders. So things like infections, HIV and tuberculosis cause growth failure. Congenital heart disease, particularly conditions that cause heart failure or cyanosis, those can impact your growth. Renal tubular acidosis, cystic fibrosis, you can go down the list. Systemic disorders often impact growth. Psychosocial deprivation is an interesting category. These are kids who are in hostile, neglectful homes, and they have stunted growth. And what's interesting is you can throw growth hormone at them, won't work. But if you pull them out of that hostile environment, put them in a loving, nurturing home, they will enjoy catch-up growth without any pharmacologic intervention, which really speaks to the importance of nurturing for the health and well-being of children. Genetic disorders, as many of you know, a lot of the genetic syndromes have short stature as part of their phenotype, and that's why we often have growth charts specific for genetic syndromes. For example, for trisomy 21, for Turner syndrome. Now we're seeing more and more kids who have private, changes because we're doing more genetic studies, and a lot of them have growth as part of their phenotype as well. And last, endocrine disorders. And why do I say last? Because people often think short stature growth, must be the growth hormone. Do you know the estimated prevalence of growth hormone deficiency in the United States? Any guesses? 10%? 1 in 3,500 children, less than 1%. And how many of you know kids on growth hormone? So we're treating a lot of non-growth hormone deficient short stature, but honest to goodness, growth hormone deficiency is actually rare. Much more common is hypothyroidism, Hashimoto thyroiditis. Cortisol excess also stunts growth. Now, endogenous Cushing's is pretty rare in childhood, but exogenous steroid treatment for asthma, allergies, rheumatoid arthritis, we all see that in our clinics. So differential as broad as general pediatrics. In terms of delayed puberty, you always want to do a family history. And when I started out in endocrine, I was a first-year fellow, Tom Oshang, who was our division chief, said, okay, Adda, this is how you learn endocrine. You're going to take care of the patients, and at night you go home and you read the ped endocrine textbook. I recommend this one, because in those days there were more books than there are now. So that's what I did. I went home and I read the textbook. And when it came to constitutional delay of growth and puberty, what it said at that time, now mind you, this was in the late 1990s, it said constitutional delay of growth and puberty, quote, is a condition that occurs in males, end quote. Well, thankfully, Mark Palmert has done research in the timing of puberty in children, and this is one of his early studies back in 2002, and it was a retrospective study looking at delayed puberty in the kids who come in. And as you see in the graph here on the left, males are on the left, females on the right. Yeah, we're seeing a lot more males than females. Constitutional delay, which is this bottom black bar here, this is how many we're seeing in males. But yeah, we see it in females. And when they looked at the history, girls or boys could inherit it from mom or dad, and they could have a sister or a brother who also had delayed puberty. So constitutional delay is a classic example of ascertainment bias. Yes, it happens in both, but we tend to see more boys, and I think a lot of that is because of the graphs that I showed you earlier. The late boys, they're the last to grow, so they're the ones who are most distressed and seek medical attention. When you're seeing a child with delayed puberty, the number one question you want to ask on review of systems is, how is your sense of smell? Sounds a little odd. I actually ask the kids, can you smell what's cooking for dinner? And the reason that that is the number one question is something called Kallman syndrome. And Kallman syndrome includes congenital hypogonadotropic hypogonadism with anosmia, so impaired sense of smell, and it can sometimes be associated with other developmental defects. Kallman syndrome arises from a failure of the GnRH neurons to migrate from the cribriform plate to the hypothalamus. But part of that neuronal migration also includes failure of development of the olfactory bulb. So that's the link between the puberty and the sense of smell. Kallman syndrome is estimated in 1 in 30,000 males and 1 in 120,000 females. And now there's been over 20 genes that have been identified and involved in this neuronal migration pattern. And a part of the list is seen here with the traditional one, COL1 or ANOS1, which makes it X-linked recessive. In terms of primary amenorrhea, the definition is no menses by 3 years after telarchy or by age 15 years. And your primary workup always includes an LH and FSH to look for premature ovarian failure. That is the most common cause. And also should include a pelvic ultrasound to exclude Meyer-Rokitansky-Kuster-Hauser syndrome, which refers to Müllerian aplasia. And what that syndrome involves is a congenital aplasia, so congenital failure of formation of the uterus and the upper 2/3 of the vagina. So these girls are 46XX with normal secondary sex characteristics. They have normal functioning ovaries, so all of puberty proceeds normally, but you're waiting for a period, and nothing is happening. That's because there is no uterus, there is no endometrial lining to shed. The syndrome occurs in about 1 to 4,500 or 5,000 women, depending on which series you read. It can be isolated or associated with renal, vertebral, auditory, and cardiac defects. It can be sporadic or familial. And in terms of treatment, that involves psychological counseling. You can create a neovagina. And in terms of pregnancy, it can be achieved through surrogacy or through a uterus transplant, which was first performed in Sweden in 2014. So I want to speak to you about the role of gender in decreased growth and delayed puberty and its management. And as I had shown you before, because boys are later than girls, the delayed boys lag behind everyone else. Everyone else is taking up with their pubertal acceleration. So the delayed boys tend to be the most distressed and the ones who seek medical care most often. But again, like that old pediatric textbook, don't let that fool you, and don't miss out on the girls. So this is a graph looking at the sex of US growth hormone recipients across the 4 growth hormone registries by year of age at initiation of treatment for idiopathic short stature. The x-axis shows age, the y-axis shows the number of subjects in these 4 registries combined. And as you can see, the male chart in blue, the female chart in red, yeah, boys outnumber girls all the way, and particularly dramatic is up here in adolescence. So again, with all the comments that I've made about the growth spurt and the timing of puberty, not surprising that the peak age at which we start growth hormone for the boys is 1 year later than the girls. And again, it's around the time that we worry about puberty. But even though puberty amplifies this gender difference, it's not the whole story. Because when you look at this graph, the boys are significantly more than the girls every single year of age, except for that very first year of life. And in the first year of life, congenital growth hormone deficiency, we tend to be alerted to that more because of neonatal hypoglycemia, neonatal hyperbilirubinemia, microcephalus in boys. We're not focused on the growth yet. So no gender difference there, but once you start worrying about the growth, the boys outnumber the girls forevermore, and puberty just amplifies it. So we did this study where we looked at the factors that could be associated with short stature, so height below -2¼ standard deviations. We picked that cutoff because the FDA picked that cutoff as the threshold for treating idiopathic short stature. And I wanted to see, okay, if boys outnumber girls so often, is growth failure happening more often in boys and girls, and what are the factors associated with it? So we looked across our primary care network, and we had over 145,000 children with complete data. And this is the results of the regression modeling of height below the cutoff for idiopathic short stature. And working down the table, sex, not associated. Race and ethnicity was. So Black children had a 0.66 partial odds ratio compared to white children, whereas Asian and Hispanic children had an increased risk compared to white children of having short stature. Age was also significantly associated, which kind of makes sense. The older you are, the more time you have to accrue a height deficit. Prematurity was a strong predictor of short stature. BMI Z-score was also significantly associated, so a lower BMI, the more likely you were to have growth failure. So again, alluding to those comments I made earlier about the importance of nutrition. And Medicaid insurance coverage was associated with a higher risk of growth failure compared to those who had private insurance. Practice location, being in an urban or a non-urban clinic, or the number of well visits in the 3-year window was not associated. Now, all of these factors were chosen because of associations on univariate analysis. So for example, the number of well visits, the children who had short stature significant enough for the ISS cutoff, they had on average 2.2 plus or minus 1.2 visits in that 3-year window. And the non-short kids had an average of 2.3 plus or minus 1.3 visits in that 3-year window. So all of you here obviously can say, yeah, that's clinically meaningless, non-significant, that's not a difference. But when we had a sample size that's over 145,000 with that kind of power, that tiny difference, which means nothing, got a p-value of less than 0.001. So when you have a study that's this ridiculously overpowered and sex is still not significant anywhere, to me that makes it the single loudest negative finding I've ever heard. And just to show you that I'm not bamboozling you with statistics, here are histograms of the raw data. So these are the height Z-scores of girls on the left, boys on the right, with the outlier box plot on top. And as you can see, they look pretty much identical. And you can sit there and say, well, of course they're identical because we calculate height Z-scores for boys and girls separately. So of course the same percentage will be at the same Z-score for each of them. And you would be correct if we were asking how many children, boys or girls, fall beneath each of the height Z-scores. But we're not. We're asking how many boys and girls in our population fall below -2¼ standard deviations on the growth chart, which means we're comparing our kids to the reference population that the CDC used to make the growth chart. And there's two very important ways in which our population could be different from the CDC reference population. The first one are large population issues, right? So they could have different compositions in terms of racial ethnic groups. There could be secular trends. And in fact, we see evidence of that in the data. So the mean and median heights of boys and girls are all above 0, meaning our population as a group was slightly taller than the reference population that the CDC used to create the growth charts. The second way that our population could differ from the reference population is that our population included everybody, whereas the CDC limited to healthy children growing normally, right, because they wanted to create a growth chart. So if our population included everybody, that means it included all the kids with all the different growth problems, all the different causes of growth failure. Well, if we're treating 3-to-1 boys to girls for idiopathic short stature, I would expect there to be a blip, some kind of bump down here to explain why we're treating so many more boys than girls, but there just isn't any. And looking at gender bias in short stature referrals, we did a retrospective study 1 year in our clinic. Boys outnumbered girls about 2-to-1 in terms of who came to see us. This is a histogram of the height Z-scores. Girls are in gray, boys are in black. You don't need to do the statistics. You can see it with your eyes that the gray curve is shifted to the left of the black curve, meaning the girls as a group were shorter than the boys. The girls also had a greater height deficit from their midparental height than the boys did. But importantly, it's not just the height of who comes in, but what's the underlying cause. And as you see here, almost double the number of boys than girls came in for normal height, so height within 2 standard deviations of either the population mean or the midparental height. The short but healthy group, so the familial short stature, constitutional growth delay, those did not differ. Neither did the non-organic causes, so all those systemic diseases that I talked about. But look at organic disease. 15% of the boys had underlying organic disease versus 41% of the girls. In other words, the girls had a risk ratio of 2.7 with a 95% confidence interval of 1.8 to 4.2 relative to the boys to have an underlying organic disease. So not only were fewer girls coming to see us, they were coming in with more severe short stature, and they were more likely to have an underlying organic disease. So then I looked at kids who were not coming to see us. And I was looking retrospectively at the electronic health records of 4 interurban primary care practices in Philadelphia. Here we had almost 33,500 children. 70% of them had Medicaid insurance, 87% of them were African American. And the graph there shows a percent of children with growth faltering is in black, without growth faltering is in gray. And as you can see, 92% of the children with growth faltering saw neither an endocrinologist nor a gastroenterologist. They were being managed by their primary care docs. I said, okay, let's see what kind of testing the primary care docs do. And there are only 2 tests that were significantly associated with gender. The first one was the growth hormone IGF axis. So for some reason, pediatricians were looking for growth hormone deficiency twice as often in the boys with growth faltering than the girls. Chromosomes was also associated with sex, which makes sense because, as you all know, Turner syndrome causes short stature in girls only, so we should be looking for Turner syndrome in girls only. But in this population, a third of the girls had chromosome testing age 12 years and up, which to me says the pediatricians were responding to the delayed or lack of puberty more than the short stature, which was present in every single one of those girls before they reached adolescence. So the kids who don't come to see us, even the primary care docs in the community, are looking for short stature and growth problems less often in girls than boys. So I want to take this opportunity to talk to you a little bit more about Turner syndrome. This is the original plate from Henry Turner's publication in 1938, and he called his syndrome a syndrome of infantilism, congenital web neck, and cubitus valgus. So infantilism refers to the fact that these adult women all are prepubertal in terms of their secondary sexual characteristics. The web neck, I think you can see most obviously in the woman in the middle, and that's from the in utero. Many of them have cystic hygromas that get resolved, and then they have the redundant skin. And cubitus valgus refers to the carrying angle in the elbow. So all of these women were asked to stand with their arms straight by their side. And as you see, the arms don't look very straight. They have these increased carrying angles here. But then when the AAP looked at the frequency of features that have been associated with Turner syndrome, the only one that's 100% besides female is short stature. So if we look at even what Henry Turner described, the infantilism, okay, the gonadal dysgenesis is only about 90%. So about 10% of girls with Turner syndrome do undergo puberty, and some of them have gotten pregnant also. The web neck, yeah, that is only 50%. The increased carrying angle or the cubitus valgus, that's only 70%. So what this says is you can be a perfectly normal appearing female, have unexplained short stature, and still have Turner syndrome. And why is that important? It's not just about giving growth hormone to make them taller, is that Turner syndrome has a lot of associated health risks, primarily cardiovascular abnormalities. So this was an old study back in 1998, when even then they knew 40% of the girls with Turner syndrome had structural defects, most of them like coarctation of the aorta, bicuspid aortic valve, aortic stenosis, and 16% had non-structural defects, including hypertension and conduction defects. Well, that was 1998. Fast forward to today and today's guidelines, and we have an even greater appreciation of the prevalence. So today we do cardiac magnetic resonance imaging, and we can detect aortic root coarc that's missed by echocardiography. And we can pick up vascular anomalies that are otherwise asymptomatic. When you perform ECG in adults, women with Turner syndrome have a lot of conduction and repolarization abnormalities. So the new guidelines are more aggressive. They recommend comprehensive monitoring of the cardiovascular system throughout the lifespan, even if your initial echo is normal, and also recommend aggressive treatment of hypertension. And the reason is to prevent aortic dilation, dissection, or rupture, because women with Turner syndrome have a standardized mortality ratio of 2.86, with a 95% confidence interval of 2.18 to 3.55. And that risk is further increased by pregnancy and by strenuous isometric exercise. So diagnosing Turner syndrome can literally help you save a life. We're talking about something that is life-threatening, increased mortality risk. It's not just about height. Height is just your clue to get you there. Okay, so let's talk about the premature ovarian failure, because that is what many people focus on in Turner syndrome. And when women and girls with Turner syndrome and their families are surveyed, this is the one that causes the most distress. So as I mentioned earlier, premature ovarian failure is in 90% of girls, meaning 10% of the patients spontaneously undergo puberty. And in order to manage this, you monitor the gonadotropins, and it's recommended to start estrogen replacement at a more normal age. So start at 11 to 12 years and increase the dose to adult dosing over to 2 to 3 years to mimic spontaneous puberty, and then you add cyclic progesterone. Back in the day, when Turner syndrome was overlooked and diagnosed late, the response was, well, just don't do puberty. That buys you more time. Treat them with the growth hormone, and then when they get to a height you want, then you can start puberty. Well, you can imagine why a lot of 15 and 16-year-old girls didn't like being prepubertal when they were walking the hallways in high school. So the name of the game is diagnose it earlier, get the growth hormone on board earlier. That way you don't have to delay the induction of puberty. And I just want to remind everyone that yes, women with Turner syndrome can get pregnant. About 2 to 3% has been the rate that's been reported, and 38% have had healthy pregnancy outcomes. Otherwise, a pregnancy can be achieved through in vitro fertilization with surrogate egg donation or oocyte cryopreservation if the girls are brought to a reproductive endocrinologist early enough. But again, remember that caution that the risk for aortic dilation and dissection is increased with pregnancy. So that must be taken into account when counseling these young women. And finally, the short stature, because that's why we're here. There is the Turner syndrome growth chart. So the red lines reflect the percentages of girls who are unaffected. The lines below are girls with Turner syndrome. And the short stature of Turner syndrome starts in utero. They have mild IUGR, so their average birth length is -1 standard deviation, so still in the normal range, but shifted down from the unaffected population. The growth failure presents in childhood, so the first 2 years they have slow growth, then they have childhood growth that's a bit below normal, and then they have the absent pubertal growth spurt. So the mean final height is reduced by 13 to 19 centimeters relative to the unaffected local population. So I just want to point out again, that's the Lion growth chart. That was a study made in France. Chowan had a similar study. They created a Turner syndrome growth study from Scandinavia where the unaffected population is taller, and lo and behold, their girls with Turner syndrome are taller than the girls in the Lion population. So yes, Turner syndrome impacts your height, but the background, genetics still plays a role. And the short stature of girls with Turner syndrome has been attributed to haploinsufficiency of the SHOX gene. SHOX stands for short stature homeobox containing gene. It was originally called PHOG, pseudoautosomal homeobox containing osteogenic gene. and it's in the pseudoautosomal region of the X chromosome. There is a second SHOX homologous gene on chromosome 3 called SHOX2. That's more widely expressed, unrelated to Turner syndrome. And normal expression of SHOX occurs in the mid portion of the limbs and the first and second pharyngeal arches. So not only has SHOX been implicated in the short stature of Turner syndrome, but it may also contribute to the cubitus valgus, the genu varum, the high arched palate, the micrognathia, and the sensory neural deafness that occur in more frequency among these girls. Okay, so therapeutic interventions. Briefly, the management, 6 months is a good time frame to monitor growth and puberty. So you want to calculate the growth velocity, you want to do serial exams to see the pubertal tempo. And remember, differential as broad as pediatrics, whatever the underlying cause is, treat that, focus on that. Well, what about treatments specifically for delayed growth and puberty? Low-dose testosterone has been used for decades to treat constitutional growth delay in puberty because puberty is the only time of life when you have positive feedback to the pituitary and hypothalamus. And so the thinking is if you give a little poof of testosterone, that'll turn on the hypothalamus and pituitary, and then puberty will get going. And so you see there the protocol that we often use. And what I usually do is do 3 months. This is a monthly injection. So you give it for 3 months. Then you skip 3 months, do nothing, and then I assess the boy at month 6 to see if it's sustained. If it's sustained, that means great, he took off. And if not, you can, repeat it with a little bit higher dose of testosterone and see if that takes off. And if not, then he may need, testosterone replacement to induce puberty fully. But just as a reminder, this can jumpstart puberty. This does not increase adult height. So if the boys are coming to you because they want to be taller as adults, gutting into puberty faster actually means their growth plates will close sooner. So it doesn't make you taller, but if you are impatient and are distressed now, this is an option. Well, how about the converse? How about using GnRH agonists to buy time to grow? And so this was a study that Jack Yanofsky's group did at the NIH, where they took healthy adolescents with low predicted adult heights of minus 3.3 plus or minus 1.2 standard deviations. And they were randomized to either placebo or GnRH agonist for a mean treatment of 3.5 plus or minus 0.9 years. And the outcome is what was their adult height. And what they found is that at the end, yes, the children treated with GnRH agonists were taller, but they increased their height Z-score by 0.6, which when you do the math, that translates to 4.2 centimeters, which is less than 2 inches. So they were treated for 3.5 and some of them up to 5, 6 years to get less than 2 inches in height. But at the same time, the groups treated with GnRH agonists had decreased lumbar bone mineral density, and they had a deficit of minus 1.6. So that is because you need estrogen to strengthen the bones and not just mature the growth plates. Another finding in this study that the authors didn't comment on is that they had a pretty big dropout rate. And they didn't comment, but it doesn't take a big stretch of the imagination to wonder why a 15 or 16-year-old doesn't want to be Tanner 1 at age 15 or 16 in high school. So yeah, great idea, but you gain less than 2 inches in height at a bigger cost to your bone mineral density. And so the conclusion was that this treatment cannot be routinely recommended to augment height in adolescents with normally timed puberty. I'm not going to go into this in the interest of time, but I just wanted to share with you, this is a great reference if you need for inducing puberty in kids who need help in terms of sex hormone replacement. But instead, I wanted to share with you some illustrative patients. And to show you that I walk the walk and don't just talk the talk, I intentionally chose 3 girls to highlight with you. And these 3 girls that I will share with you, I'm presenting to you exactly as they came to me. I made no changes for teaching purposes. This is real life. Okay, so patient number 1, she was a 12-year, 3-month-old girl who came to me for follow-up of Hashimoto thyroiditis that had been diagnosed 17 months earlier. She was on levothyroxine replacement. Her TFTs were normal. Everything was great. But I always look at the growth chart of my patients before I walk in the door because I always want to see the objective data because the subjective concerns of the family don't always match the objective. So I like to see my objective data first before I walk in the room. Here's her growth chart. And as you can see, her height started dipping down. Well, this concerned me, and it concerned me for two reasons. First of all, this patient had moved to New York City 2 months earlier to become a professional ballerina. She was doing a 5-week training course over the summer. She was in the ballet academy in the fall. She was dancing to 20 to 30 hours per week plus rehearsals. Like, so what are the 20 to 30 hours if those are not rehearsals? But that's professional. She switched to homeschooling because she dances so much. And the reason this was pertinent is that many times when we see heights kind of, wiggling on the growth chart, we think, well, maybe it's, posture, maybe it's the way they're standing. This girl's back was so straight, like she couldn't slouch if she tried. So I knew that that dip was real. It wasn't a measurement issue. The second reason that I was concerned is that when I calculated her height velocity, it was only 4.6 centimeters per year. But she was Tanner stage 3 for breasts and 2 for pubic hair. So if you look at Tanner's chart, here is 2 for pubic hair, 3 for breasts. She should have been on the upswing. Her height velocity should have been increasing, not decreasing. So this is a big, big red flag. Next, looking at her weight also dropped and her BMI dropped. And I thought, oh, of course, she's a prima ballerina. And this is what came to my mind. These are images, the prototype, the quintessential ballerina. They must have these very long, flowy limbs, and they must have, a body that connects them that's of minimal weight to make it easier to jump and be lifted. So these were the images in my mind. And for those of you who know nothing about ballet, I'm sure many of you still know Jelzy Kirkland there because she's the one who danced in the Nutcracker that's shown on TV every year at Christmas time with Mikhail Baryshnikov. Jelzy Kirkland famously suffered from anorexia nervosa, and she fueled her dancing with cocaine instead of food. So this is a world that my patient is now in. And thankfully, Misty Copeland became the first African-American prima ballerina in the 70-year history of American ballet theater. And she broke a lot of ceilings, not just in terms of race. She didn't start dancing until she was 13, which is unheard of old. And when she started dancing, people told her, yeah, don't even bother. You've got the wrong body type. Like, I wish my body was that kind of wrong. So I'm hoping the ballet world is getting better, but the prototype is still the women in the slide that I showed you, and that's my patient's world, and I'm thinking, great. In the best case scenario, she's just not eating enough to keep up with her demand. In the worst case scenario, she's developing an eating disorder. So I told her, let's do a 3-day diet history, let the dietitian analyze it, let's figure out where your deficit is, and let's go with that. I go to close the chart, I was like, oh, right. She came to me for follow-up of Hashimoto thyroiditis. I totally forgot because that was like autopilot. There was nothing to do for that. It wasn't a growth visit. But the minute I saw Hashimoto thyroiditis, my brain went bing, bing. Hashimoto thyroiditis is statistically associated with a higher risk of celiac disease. So I'm like, fine, I'll be a good doobie. I'll check your celiac panel. And when I check the celiac panel, I always check the CRP to screen for inflammatory bowel disease as well. And I'm like, and if I'm going to stick you, I'll get your growth factors because growth hormone deficiency is one of the few things that can slow down your growth when you should be shooting up with puberty. And I'll get a bone age because that's what pediatric endocrinologists do to help us, frame our thinking when growth and puberty are a bit out of whack. But man, I was all ready for that 3-day diet diary. You know what happened? I never got it. Because before she could even complete the 3-day diet diary, her celiac panel came back and the whole thing lit up. It was totally positive. And we did do endoscopy, and duodenal biopsy did confirm the diagnosis of celiac disease. So I just want to point out these references. From 1992, we know of something called monosymptomatic celiac disease, where short stature can be the only presenting feature of celiac disease. So you don't need to wait for belly symptoms. You can just see growth failure in a child and diagnose celiac disease. The next reference is a great review in Nature Reviews Gastroenterology and Hepatology of the extraintestinal manifestations of celiac disease. And the last paper in JAMA Pediatrics looked retrospectively at kids diagnosed with celiac disease and said, if the doctors paid attention to the growth failure, on average, we would have diagnosed celiac disease 2 years earlier than we did in real life by not looking at the growth chart. So remember celiac, even if there's no GI symptoms. So to give you the follow-up of my patient, she came back 6 months later after being on a gluten-free diet, and she said she had less headaches and fatigue, which kind of surprised me because when I did the review systems at the previous visit, she was totally fine. In retrospect, because these symptoms are so vague and, coming in just so subtly, she really wasn't that fine. Not surprising to me, she said she's actually working better at ballet, having the strength on this gluten-free diet. And here's her growth chart. Her height velocity increased to 10 centimeters per year. Her Tanner stages stayed the same. So the height acceleration from 4.6 to 10 centimeters per year was not pubertal acceleration, it was catch-up growth. Okay, illustrative patient number 2. This is a 14-and-a-half-year-old girl who came to me with delayed puberty. Her sister was also late with menarche at age 14 and a half. Mom was a little bit late, menarche at 13. Dad's age of puberty was unknown. My patient's telarchy, so her breast development started at age 14 and a half and was isolated. So again, late. You see her growth chart there on the right, and it was back in the day when we were still doing paper charting. So the arrow indicates the mid-parental height. So there's a background of familial short stature. The mid-parental height is about 10th percentile. But as you can see, the height is dropping, and so is the weight. So her past medical history had some ADHD, some developmental delays, some headaches, rarely with emesis at school. She wears glasses for myopia, asthma, and recently discovered hearing loss. So, pretty common complaints that we see in the pediatric clinic. And, looking at her weight curve, I was asking her about, her nutritional history. And what I was told is that she eats and eats, but just doesn't seem to gain weight. She's been on ADD meds since the age of 9 years, but she was a picky eater even before then. She had been on early intervention and drinks Ensure now and then as a nutritional supplement. So the rest has all been negative. And on her exam, she was a very thin girl. Her height was -3 standard deviations, her weight was -4.38, and her BMI was -2.73. She had no 12-year molars, which to me suggests she likely will have a delayed bone age. She did have braces. She had a scaphoid abdomen because she was so skinny, hypoactive bowel sounds. She had Tanner stage 3 breasts. The right was a little bit bigger than the left, but that can be a normal variant. She had no pubic hair and scant axillary hair. So yes, indeed, her bone age was delayed. It was 13 at a chronological age of 14 and a half. And by this bone age, 96.4% of adult height is already achieved by most girls. So she came to me already pretty late in the game. And so again, my assessment, there was an element of familial short stature in the background, but she's, been below the 5th and losing ground. There's some nutritional component, but because she's so late, I'm not going to do what I usually do, which is tackle the nutrition first and then reassess. I'm like, I don't have time to do that. I got to do them all at once. So I got all the labs, and her IGF-1 was -2.6 standard deviations. IGF-1, or the insulin-like growth factor, that is made in response to growth hormone. About 70% of your circulating IGF-1 comes from the liver. Same thing with the IGF-binding protein 3, which in her case was normal. And that still didn't tell me anything, because IGF-1 can be lowered by growth hormone deficiency. It can also be lowered by malnutrition. So again, had she been younger coming to me, I would have tackled the malnutrition first, then remeasured the growth factors, and then done the stim testing. But because we were so late in the game, I'm like, let's do it all. I don't have the time to do this sequentially. We did the stim test, and she failed. Her peak growth hormone on clonidine arginine testing was 8.01 nanograms per mil, so she had a partial growth hormone insufficiency. And on MRI, the cella was partially empty, and she had a small pituitary gland for age. That also doesn't help me, because that could be a normal variant, or it could mean that she had a hypoplastic pituitary that wasn't working so well. So the next step, for some reason the slide is frozen. Sorry, there we go. So the next step was we started growth hormone treatment at age 15 and a half, and 3 months later, diagnosed with central hypothyroidism and central adrenal insufficiency. And this is just a reminder that in hypopituitarism, sometimes you present all at once, but sometimes it's an evolving picture. And growth hormone deficiency is often the first and sometimes only hormone that could be deficient. But on diagnosing the other deficiencies, she was started on levothyroxine replacement, on hydrocortisone. She achieved menarche on her own at age 16 and a half. Her menses were regular. And she completed growth hormone treatment at age 17 and a half. So that delayed bone age really worked to our advantage. When she completed growth hormone treatment, retesting for adult growth hormone deficiency, her growth factors were normal, and she had a normal function. And so here are her growth charts in follow-up, just to show you. So the height is here on the left, the weight and the BMI on the right. Okay, the last illustrative patient, this is a 10-year-old girl, came with short stature. She was referred by her primary care doc because she didn't grow the 2 inches per year that she was supposed to. And, the parents told me they were concerned when she was an infant, and she was evaluated by one of my colleagues 6 years earlier, but the labs are all normal. And the pediatrician didn't mention it again until the recent well child visit. And you see here her growth chart. This is her height curve. The little bubble there on the right is the midparental height. So the midparental height is just above the 25th percentile. She's been below the curves her whole life. And yes, most recently, seeming to decelerate. So I went to see what was done before. But in terms of history from the parents, she's healthy, some reactive airways disease that she outgrew a long time ago. And on exam, she had short fifth metacarpals, some subtle facial findings. And her BMI was 87th percentile, so I couldn't blame nutrition on this one. And so when I looked back in her chart to see what was done 6 years ago, she had normal labs. She had a normal CBC with differential, normal chemistry panel, normal SED rate, thyroid functions, growth factor, celiac panel, cortisol, and ACTH. There's one thing missing from this panel, and that was the chromosomes. And sure enough, she was mosaic for Turner syndrome. So 16 out of the 20 cells were 45 X complement, 4 out of the cells were actually 47 triple X. And looking at the note from the endocrinologist 6 years earlier, it said, quote, I suspect her growth pattern is multifactorial, including caloric intake that is not optimal, as well as potential influence from her inhaled steroids. Suspicion for pathology is low, although have recommended laboratory testing to rule out other endocrinopathies such as thyroid disease, growth hormone deficiency, and iatrogenic adrenal insufficiency, as well as other chronic diseases such as inflammatory conditions like IBD or celiac disease. We have deferred a karyotype for now, but we'll consider this in the future depending on her growth pattern. In the meantime, we would recommend increasing caloric intake. I've provided the family with a caloric booster handout. In addition, if asthma can be controlled with less steroids, we would recommend decreasing the frequency or dosing and follow up in 6 months. Well, the family heard all the labs are normal, so they dropped it. So the follow-up in 6 months became come back in 6 years. And again, all that other stuff that I told you about Turner syndrome, she missed out on for 6 years unnecessarily because the chromosomes were not obtained up front. So the take-home points that I hope you walk away with: always interpret growth and puberty in the context of the family history. Always interpret height velocity in the context of pubertal stage. Remember that normal variation is common. In those cases, reassure. You don't have to intervene pharmacologically. Evaluate worrisome patterns and don't wait. I'm seeing that a lot from our referrals, the pediatricians following, saying, okay, there's a growth spurt that's gonna come, it's gonna come. And then, in adolescence, oh, it didn't come. And, many times it's then too late. Remember not to overlook growth and karyotype in girls. Many times, expectant monitoring is the best intervention, but if there is an underlying problem, treat the underlying cause. So thank you for your attention, and again, thank you for your warm welcome. And I'm
Thank
happy
you
to
so
take any
much. Thanks for
questions.
teaching me, and it brings back the great memories of Dr. Foster teaching me some of these things in residency, and thereafter. Um, what questions does everybody have? I appreciate all the Turner syndrome myth busting as well. That was great.
Yes,
That was great, thank you very much.
thank you.
What is the Bailey printout table?
Okay, so
And
Bailey.
how accurate is it?
Excellent question. All right, so Bailey-Pinot are tables in the back. So Grulich and Pyle is the atlas of bone ages. It's from the 1950s. In the back of the book, Bailey and Pinot did studies. It was basically a mathematical exercise where they're like, if your bone age is X, then you are X percent of your adult height. So that was the study they did. They took bone ages that measure height, and then they measured adult height. And so they calculated for boys and girls separately, for each bone age, what percentage of your adult height are you? And so that way, if you know the height now, you know the bone age, you can then extrapolate and say, okay, at 100%, this is what your adult height will be. So the Bailey-Pinot tables are broken up not just by sex, but also if your bone age is within 1 year of your calendar age, if it's at least 1 year behind, or at least 1 year ahead. And they're cited to have a statistical error of plus or minus 2 inches. Always, 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 if you're gonna give the parents a predicted adult height, say plus or minus 2 inches, because people will fixate on that number, and God forbid they don't reach that number, they're going to be mad as all stink at you. So always say plus or minus 2 inches, and there's room for error. So if they're more than 1 year ahead or behind, there aren't tables that say 2 or 3, you know, so that's one problem. Another problem is bone ages are very subjective in their reading. Another problem is that puberty is a wild card. The tempo of puberty has a big impact on your adult height. So these are problematic. And Julie, Laurie Cohen, who was at Harvard at the time, did a study where they did a computer simulation of 1,000 boys and girls with ISS, and they took 3 of the most common algorithms. So Bailey-Pinot is just one algorithm that we use to predict adult height. There are others, for example, using the Tanner stages, the Tanner references that they use more in Europe. And they used those 3 different algorithms, ran a computer simulation, 1,000 kids, what is their adult height predictions? And across those 3 algorithms, they really didn't match up well at all. So you got to take all of this with a grain of salt. But again, always, always, always remind that to parents. Don't give it as a number, because they will fixate on that. Yes.
I have a question about the gender biases. So it makes a lot of sense that like parental concern is biased by gender of the child and referral rates from pediatricians. But has anybody looked from the endocrinologist perspective? Like, do we have inherent biases in terms of who we offer growth hormone therapy to, boys versus girls?
So we did do studies looking at growth hormone stimulation testing and growth hormone treatment. And yes, girls statistically. So not only do we see fewer girls, and so we have that bias of walking in the door, but after they've walked in our door, the girls had a lower rate of getting growth hormone stim testing than the boys did. And growth hormone stim testing is your gateway to growth hormone treatment. And there were racial, ethnic disparities as well. So yeah, people in glass houses were part of the problem. And I don't think of it as a judgmental thing. The issue is we're all in the same society. We're all getting bombarded by the same societal messaging. And in our society, girls have to be pretty and skinny, and guys have to be tall. And so that's the world we're living in. That's the messaging. And so it can hit any and all of those layers, the patients, the families, the primary care docs, the endocrinologists, the neighbor, the other specialist, anybody chimes in and says, oh, your kid's short, they should get growth hormone. And we're all living in this society.
Thank you, great talk.
Thank you.
Can you comment on genetic testing
Mhm.
now that we have many options available to us
Mhm.
than we previously did? Which would be the appropriate candidate other than obvious dysmorphic features? Other things pediatricians or specialists should be looking for, like microcephaly, developmental delay,
Mhm.
so on and so forth.
Excellent question. So yes, so any neurologic phenotype does increase risk. Any sort of dysmorphism should increase risk. A big decision branch point is if it's proportional growth failure versus disproportionate. If it's disproportionate, you have a higher likelihood to have an underlying skeletal dysplasia. If it's proportionate, then it's more likely to be in the hormonal systemic diseases kind of bucket. My approach, I always get the chromosomes in girls. I do my first round of screening. I follow the kids to see what their growth pattern is. If it looks worrisome and I don't have a good answer, I will screen for shocks myself. And the reason is, depending on which series you read, it's between 2 and 15% of kids with idiopathic short stature have shocks haploinsufficiency. I think that 15 was an enriched population. I've never seen anything close to that. But the reason that I check it is that shocks is an FDA-approved indication for growth hormone treatment, so it's actionable. All the other ones, yeah, it'd be nice to know, but many of them don't have a direct treatment. I mean, yes, now we have vosoritide and there are more options, but in terms of growth hormone, that's the one that's really actionable. If I'm concerned, then I will send them to our geneticist and have them choose whether to do a panel, whether to do whole genome sequencing. But I do it sequentially. Yeah.
I had a little question.
Yes.
So for kids who are getting juvenilized by other people, and that's something I could do tomorrow, is just pay attention to like what age is this kid before I go into their
Mhm.
hospital room.
Yes.
Make sure that I meet them where they're at of their developmental age or their actual age. But anyway, have your patients who are shorter stature, shared with you like any comebacks or kind of things they can say? How did they cope with like somebody briefly or persistently juvenilizing them?
Excellent question. So as Ivana pointed out in my introduction, I started off my life as a molecular biologist, and I was interested in the role of the growth hormone IGF system in cancer development. And then I just got, pulled by the disparities that I saw in clinic, and I'm like, I just felt I had to do something. So my focus switched to the disparities. And once I saw the disparities, then I started going into the decision making. Why do some kids come for growth hormone and other people don't? You know, and looking at the psychosocial piece, because a lot of those disparities are driven by the focus on height as a psychosocial outcome. And I've been very fortunate. I've collaborated with Ken Ginsberg, who's in our adolescent medicine department. He's written a number of books for the American Academy of Pediatrics. And when I have parents coming in with questions about teasing, about bullying, about what do we do with this stuff, I refer them to Ken's books, because his books are written for parents, and they're all designed to train parents or teach parents how to foster resilience, and addresses those topics specifically. How do you deal with teasing and bullying and so on?
That's great. That's better than like just telling them to come back to have or it's really empowering. So thanks for that, and thanks again for teaching us that claim credit code 52525. I appreciate everybody joining us this morning.
Great. Thank you. Yes, so his name is Kenneth Ginsberg, Ginsburg. He has multiple books now. So if you look him up on the AAP website and refer parents there. And that's happened to me. I had, for example, a patient who has growth hormone deficiency, was started on growth hormone treatment. Her height's, been catching up. And then in year 2 of 3 year treatment, the mom came in and said, you know what? This year, there's a bully in her class. What do we do? And so traditionally we think of, oh, well, we give them growth hormone, make them taller, make the bully go away. But she's already been on growth hormone and she wasn't that short. That wasn't the answer. And so, yeah, I referred her to Ken. Yep. Great. Thank you.